Hello, my dear friends. I welcome you all in the session of this clinical case scenario to be discussed today. I hope you all are in high spirits and preparing for your examination, and you are living a wonderful life, right? So, guys, I'm pretty sure that we have enjoyed the last day session as well. Guys, I request all of you to please, let me know in the chat box that about the audio visual things, everything is perfect, so that we can start the class. Hanji, everything is okay. Guys, I'm waiting for your replies. Priya, thank you. Bindu Kumari, thank you very much. Sudhanshu, very good. Thank you, sir. So we can start the class. Thank you, Sujata ma'am. Thank you, everyone. And so let's start with the very first question, guys. This is a two-way class. Please don't feel hesitated to interrupt me. You can ask me the questions wherever you feel that the things are not clear to you. My only objective is to make the things clear to all of you, right? And to achieve the success over here. So let's discuss about the first clinical case scenario. Now, this is a question which is getting displayed in front of the screens. Read this question carefully. I am going to read this question and I will wait for some seconds so that you gather some time to collect your memory, and appropriately then we will discuss about the options. So here we go with the first question. So the first question is: a 25-year-old female presented to you with the complaints of shortness of breath, cough. She reports of chest tightness and whistling sound. On examination, her BP is 100 by 68, respiratory rate is 24, SpO2 is 93%. She also she also gives that this symptoms increases mostly when there is a change in the weather and on exposure to fragrance. Which of the following is the best initial test? Now, there is one, one approach of solving the MCQ, that if you have read this MCQ carefully, now start thinking what could be the diagnosis of this patient. Now, if you have achieved the diagnosis of this patient, only then we will be able to segregate the appropriate or the correct option over here. So, guys, I am waiting for your answer over here on the chat box. My first question is to this: what is the diagnosis of this patient? What is the diagnosis? Okay, Bindu ma'am, your answer is right. Anyone else who want to participate? Janvi ma'am, absolutely right. Okay, so guys, this lady is having what? This lady is having bronchial asthma, right? So this lady is having what? Bronchial asthma. Now let's discuss about asthma. What is asthma basically? I will come to the right appropriate option. That let me explain you what is asthma over here in the slide. According to the definition, what is this asthma? So the definition of asthma, it is characterized by chronic airflow limitation, airflow limitation, airflow limitation, and inflammation with respiratory symptoms with respiratory symptoms such as wheeze, first of all, shortness of breath, right? Chest tightness, chest tightness, right? Which may vary, which, and there is another thing, chest tightness, cough, which may vary in intensity and time. Now, this is the line which I wanted to explain it to you, that if we understand this language over here, or if we understand this, definition, asthma is very easy over here. So, what is it, my dear friend? That it is not a one-day game show. It may take a long time, right? This asthma patients can carry their symptoms for a longer age, right? Now, why does this occurs, my dear friend? Understand the concept over here. Suppose this is an airway over here. What happens, my dear friend? Any pathogen which is coming outside, or even see, if I go into a little detail of asthma can be divided into two main parts. One is intrinsic asthma, one is extrinsic asthma. Now, intrinsic asthma means, or first of all, let's discuss extrinsic asthma and intrinsic asthma. Now, this extrinsic asthma means, beta, what? That any pathogen which is coming from outside of the body and it is going to cause broncho constriction. ये क्या करेगा बेटा? यहाँ पे broncho constriction कर देगा. Now, understand the concept over here. Initially, this was the radius of an airway, but now a pathogen which has come from outside the body, due to our low immunity, or there is some changes in our body, right? Let's say it is some atopy, or it will lead to some inflammation over here. I repeat, it leads to inflammation of here, and due to this inflammation, there is a bronchospasm over here, right? This bronchospasm, what will happen to the air which is going inside? Initially, the air was going freely over here. Now, what will start happening over here, my dear friend? That this will lead to what, my dear friend? Initially, the air was going freely over here. This was a free air which was going on here. But now, my dear friend, here in brown color, I have shown you a constricted bronchus over here. Will the air be able having a proper flow or not? क्या ये proper flow बन पाएगा? नहीं बन पाएगा यहाँ पे. और जो भी flow होगा, whatever the flow is going to go, it is going to rub against the bronchial walls over here. When there is a rubbing of the bronchial walls over here, the first symptom patient will have wheeze, or what we call it as whistling sound. Second, air which we are trying to inhale is not adequate, so the patient will start feeling shortness of breath and chest tightness. I told you that the patient is having inflammation over there. Because of this inflammation, there is a mucous gland hypertrophy, right? So यहाँ पे क्या होगा बेटा? यहाँ पे क्या थे अपने पास? ये देखो, इसके ऊपर क्या था? Mucous gland था, right? So this was the mucous gland over here. So this mucous gland will get hypertrophy over here, and what it will start? It will start secreting the sputum over here, right? तो ये sputum produce करने लगेगा. Once it will start producing the sputum, so what will happen now? The patient will have cough with sputum. Depending on the severity of the inflammation, patient will have sputum or no sputum, means productive cough, or maybe patient is only having, dry cough without sputum. So this all you have to understand the concept over here. Now, the main thing in asthma is there is very important is this, which may vary over time and intensity. Which may vary over time and intensity. This is very important. See, asthma can only be segregated from COPD by this mean. Asthma can only be segregated from COPD by this mean that COPD is a persistent thing. There is no variation. Once the patient is having COPD, it will keep on progressing day by day, right? But in asthma, what happens? It may be severe. Let's say I'm just putting an example. It may be severe in winters, right? Because of the cold air. This cold air is going to cause the bronchoconstriction over here. But in summers, the patient may have a better life, right? When the patient is getting exposed to any fragrances, or patient is getting, any precipitant is coming in contact with that patient may land up into bronchospasm, right? And according to time, this may vary. Sometimes it is mild, severe, very severe, or life threatening. We can segregate. I will discuss in detail when we will have a detailed class of the respiratory system over here. So thumb rule is this, that the asthma is having a variability in time and in intensity. This is the only key feature, or there is another key feature of FEV1 we will discuss later. But as of now, just remember that variability in time and intensity is the key feature which segregates or which differentiates it from the COPD, right? So let's say now, what is in this question? This question is saying that she is having shortness of breath, cough, and she reports of chest tightness, whistling sound. All the features, clinical features, are of asthma. BP is okay. Respiratory rate is on a little higher side. Room air saturation is approximately near normal. I'm not saying normal. Normally, generally we have started considering more than 94%, but it is going on a lower side because of the bronchospasm. Now, this is the main history over here, that the symptoms increases mostly when there is a change in weather and on exposure to fragrance. Which of the following is the best initial test? Now, guys, let's discuss about the best initial test. So, can you please tell me how you are going to approach to a case of asthma? Hanji, can you please tell me how you are going to approach to the case of asthma? So, understand the concept over here. So, the diagnosis of asthma, guys. Yes, Hanji, diagnosis of asthma. First, very important thing is the clinical history. As I have just told you guys, that the history may vary according to the time and the intensity, right? So history, if in the option it is written clinical history, is very important to know. Now second, my dear friend, is what, my dear friend, is PFT. Pulmonary function test. What is it? Pulmonary function test. Now PFT can only be done at a hospital, right, or at a clinic. But now, my dear friend, even if in the option there is a thing which is written is at PEFR, peak expiratory flow rate. What it is written? Peak expiratory flow rate. Now, guys, you must be surprised to know that there is a device by the name of PEFR device, peak expiratory flow rate device, which is generally recommended to every patient of asthma. They can check their severity of asthma at home also, at a roadside also. I am just going to show you the picture of a PEFR. I hope that you are going to learn from this picture that how does this PEFR look like. Now, this is a device on the screen you are seeing. That over here, what do you see over here? That there is a male guy and he is blowing the air in this device. This device is called as PEFR device. What is this device called as? PEFR device. Now you can see over here, just a second, let me put that big camera. Hanji. Now you can see over here, guys, that there is a gauge over here. Here you can see in orange color there is a gauge over here. What this person is doing, this person is blowing the air, and you can see the markings over here. This is, you can see, I am just zooming it. This is liters in minute. Here it is marked that there is liters in minute. You can see over here. I am just, so here is this liters in minute. So whatever the, age, whatever the physical condition of this patient is, this according to the age, according to the weight, we do have a chart over here, right? So we can actually define the patient, that how much is a normal PEFR of a patient. I'm just generally talking for a person who is approximately 5 feet, 5.5 to 6 feet. Normally he is supposed to blow the air approximately between 450 to 500, right, liters per minute. Got my point? But now, if presuming this patient is of 6 feet, he is only able to blow the 250. So what does it mean? It means the patient is having bronchospasm. So it comes the best initial test. This initial test, if the patient is having this device at home or even at an office, or even he is putting it in the pocket, he can do, and he can check this severity of the asthma. Got my point, guys? So do remember the best initial test is the PEFT. PEFT is done at hospital level, but if it is given in PEFR, then PEFR can be done anywhere. Now coming to the second one, what is this methyl choline challenge test? See, this is basically what you call it as bronchial provocation test, right? This methylcholine test is basically done to provoke, right? Provoke. This methylcholine is basically a derivative of acetylcholine. We know that what is the function of the acetylcholine. The acetylcholine causes bronchoconstriction. Got my point? Acetylcholine causes bronchoconstriction. Methacholine is the derivative. So we gave intradermal methacholine and the patient lands up into the bronchospasm. This test is only done for research and development purpose or to rule out some allergic rhinitis or some cystic fibrosis. So this test is ruled out. Right. Now chest x-rays. Guys, do remember chest x-rays. Chest x-rays in asthmatic patient is generally normal unless other parenchymal abnormalities. Other parenchymal abnormalities like pneumonia, right, like tuberculosis or any other infected disease which is affecting the tissues. Unless other parenchymal abnormalities, the chest x-rays is going to be normal. Now you must be wondering, sir, why the chest x-rays is going to be normal? See, it is very well understood that where is the problem? The problem is in the airways, right? Chest x-rays is going to tell us about the parenchymal or the tissues problem of the lung. That's why over here DLCO, DLCO is not done generally, but DLCO is done where where there is some hematological problem or there is some bleeding, right, in the lung condition. So DLCO is going to be on a lower side over here. So this is the best initial test is the PEFR. I hope you have understood this question very well. Okay, Ji. Yeah, beta, Akhil, spirometry is also known as PEFR. But what the device I have told you is this. This is called as PEFR device. Someone can purchase the device just costing near about 350 to 400 rupees. Got my point? And they can keep it as long as they want and they can monitor their asthma. So the best initial test can be done even at home, at a roadside or even at an office. Okay, Ji. Chalo, let's discuss the next question. Hanji guys. So what is this next question is telling us? A 60-year-old male patient presented to you with a history of fever, with chills, shortness of breath, cough, with chocolate color sputum for the last 7 days. Right? He reveals that he has worked as a transporter for more than 40 years. On examination, you find the heart rate was on the higher side, 112. BP is at a borderline lower side, 90 by 58. SpO2 is lower side, 90%. Systemic examination shows lymphadenopathy in axillary region. Very important. Auscultation bilateral clefts in intrascapular region. Which of the following is the most likely cause of this condition? हाँ जी बताइए. हाँ जी, I am waiting for your replies, guys. चलिए, think logically. Baljinder sir, please rethink once again. Okay, guys. I am giving you a clue over here that here it is written a transporter for more than 40 years. Now, I have highlighted this question over here that this patient is a transporter for more than 40 years, guys. Now think, I have given you that there is a clue over here that he is a transporter, maybe he is a lorry driver or a truck driver or a taxi driver. Now think, tell me the answer. I have given you a very good clue. अच्छा, ये चीज तो समझ आ गई है ना. दिस थिंग इज वेरी क्लियर टू ऑल ऑफ यू दैट दिस पेशेंट इज सफरिंग फ्रॉम निमोनिया. वी जस्ट ओनली नीड टू recognize the pathogen over here, right? Understand the concept over here. So let's see an approach over here. Patient is having fever, one thing, with chill, shortness of breath, cough with chocolate color sputum. Where does it go? First of all, we know that this diagnosis is pneumonia, right? Diagnosis is pneumonia. Now the next line is this: patient is a transporter for more than 40 years. Means transporter means maybe he is a as I said just now, that the patient is a truck driver or maybe he is a taxi driver or a bus driver, whatever he is. So he might have intimated with some professional sex workers, and from there they might have received the HIV. So this patient seems to be an immunocompromised patient. So immunocompromised patients. Next, all these features, clinical features: low blood pressure, SpO2 90%, auscultation, bilateral Krebs. Krebs is the feature of pneumonia in the early phases of pneumonia. What do we find is in the pneumonia we do have what you call it as four phases of pneumonia. The first phase is what, my dear friend? What is the first phase? The first phase is called as stage of congestion. Stage of congestion. And what do we find over here? We find Krebs over here. In stage 2, it is called as stage of red hepatization. Red hepatization. What do we find? We find bronchial breath sounds. Bronchial breath sounds better. And in the third stage, what we are going to see, that in stir stage, this is called a stage of gray hepatization. Gray, there, here we find again bronchial breath sound, and we do have the last stage of resolution. Stage of resolution. What do we find over here? Again, we find the Krebs over here. But now, my dear friends, according to the stage, if I go over here, what happens over here, that in the crepitation, the patient is going to develop all the symptoms. The patient is going to have an inflammatory stage over here. And we know, due to this, when this all cascades are working over here, it is going to create the parasympathetic nervous system activated, and because of this, the heart rate is going to increase over here. The blood pressure is going to be on a lower side, right? The oxygen demand has increased because of the inflammation, but the utilization and is even more. That's why the saturation is on a lower side. Some more, this patient is having systemic lymphadenopathy in axillary region. Now we know that this patient is a truck driver or the patient is a transporter. So most likely, I have told you, the patient has engaged into some physical involvement, or let's say the sexual involvement with some commercial sex workers, and from there they might have got the HIV and got immunocompromised over here. So from the starting of this question, I just wanted to figure it out, or I just wanted to limelight the concept of PCP, pneumocystic kidney pneumonia. Earlier it was known as PCP or pneumocystis jirovecii over here. So let's discuss about pneumocystic jirovecii. So what is this PCP? It's basically, my dear friend, it's an opportunistic fungal infection. It's a opportunistic fungal infection, right? Which causes pneumonia. In immunocompromised patients. In immunocompromised patients, right? And particularly to those with particularly to those patients with HIV or patients who have some organ transplant. So you have to recall your memory, guys, that it is not just the HIV. What I am saying, immunocompromised is HIV. Patient who has gone for a, let's say, I am just putting an example, organ a renal transplant patient was immunocompromised over here. This is an opportunistic infection, or patient is having some hematological malignancies. Hematological malignancies, right? Or patient who have used high dose of glucocorticoids, high dose of glucocorticoids, glucocorticoids. So these all are the some of the examples where the patient can get immunocompromised, and this PCP can occur over these patients. So what basically happens over here when this PCP starts working, when the CD4 ratio is less than, very important guys, when the CD4 ratio is less than 200 cells, right? CD4 T lymphocyte ratio, T lymphocyte count, not ratio, sorry. T lymphocyte count is less than 200. Mark my words, and this is very important what I have written over here. CD4 less than 200. T lymphocyte CD4 is less than 200 at that time, and this is the time when this PCP can cause some pneumonias over here, right? So what will be the clinical features over here in a case of PCP? What are the clinical features, guys? Hanji, I'm just rubbing it out so that I can make some space over here. So guys, what are the clinical features? Yes, guys, can you please tell me what are the clinical features? So the first clinical feature, the patient is going to have some symptoms of subacute pneumonia. The patient is going to have some symptoms of subacute pneumonia, right? Patient can have dyspnea, right? Patient can have, cough. But try to understand this, guys, that this is a atypical type of pneumonia. क्या है बेटा? Atypical type of pneumonia है, and we all know that this is non-productive cough. Mainly, no, I am just saying that it can be a productive, but mainly the patient is having non-productive type of cough, right? Patient can have extrapulmonary manifestations also. Patient can have extrapulmonary manifestations. So what are the extrapulmonary manifestations patient can have over here? So the patient can have an extrapulmonary manifestation that it can include almost any organ over here. Either it is lymph nodes, either it is spleen, liver, either it is kidney. It is going to involve anything over here, right? Okay, ji. So even in the MCQs, you may find from the lab investigation that the patient is going to have a higher lactate dehydrogenase. LDH is going to be increased over here, right? Okay. So how you are going to make the diagnosis? My question is this: how you are going to make the diagnosis over here? So once we are going to make the diagnosis, first of all, what we are going to do? We are going to do a sputum culture and sensitivity. We can send it for PCR, polymerase chain reaction test, right? We can do organ specific, and secondly, we can do a bronchoalveolar lavage. And in bronchoalveolar lavage, obviously, we are going to rule out for this organism also, right? And basically we can do a fungal assay over here. We can do some fungal assays like beta D glucan can be done, right? This all can be done. We can check for the beta D glucan. This is particularly for the PCP test over here. Now you have made all these investigations over here, guys. So how you are going to treat this case? Now my question to you is this: that guys, what is the treatment? What is the prophylaxis of this PCP, and what is the treatment? Anji guys, can you please tell me what is the prophylaxis and what is the treatment? So first of all, tell me about the prophylaxis. Prophylaxis of PCP. My question is this. I am waiting for your replies. Okay, pentamidine, very good. Anyone else? Cotrimexazole, okay. Okay, so for prophylaxis, if they ask, first of all, the first choice what we are going to give, my dear friend, it is what? It is trimethoprim sulfamethoxazole, right? Trimethoprim sulfamethoxazole we are going to give. Alternative, what we are going to give is alternative what we are going to give is, yes, we can give dapsone. Absolutely right, guys. We can give dapsone, plus second option we can give dapsone. We can give dapsone alone, plus we can give dapsone or trimethamidine. Trimethamine, plus we can give leucovorin. Leucovorin, or third option, as who just said me pentamidine. Yes, Sahu Patel, you said right. We can give pentamidine. So these all are the drugs which are given for the prophylaxis of the what we are going to give for the prophylaxis of the PCP over here, guys. Okay. So if we talk about the treatment of this treatment, guys, Hanji, अब बताइए, guys, can you please tell me what is the treatment? Now my question changes, and now I am saying what is the treatment, guys? जी बताइए sir, what is the treatment of PCP? Now the question has changed. What is the treatment of the PCP? So guys, the treatment for the PCP, obviously again the first choice is, first we are going to give is again trimethoprim sulfamethoxazole, right? Second, alternatively we can give atovaquone. We can give atovaquone plus primaquine. We can give atovaquone plus primaquine. Then we have the option of giving pentamidine. Pentamidine, or if they ask you the adjuvant agents, adjunctive agents, then my dear friend, we can give two drugs. These are the corticosteroids. We know that there is inflammation, so inflammation needs to be reduced. So what we need to give is prednisone, or we can give methyl prednisone, or we can give methyl prednisone. So guys, this was a quick revision of PCP. I hope you have enjoyed this question and you have learned this thing. Yeah, so very good. Okay, so can we move to the next question? Hanji, चलो अगले क्वेश्चन पे चलते हैं. जी बताइए, व्हाट इज दिस क्वेश्चन टेलिंग अस अबाउट? 42-year-old male who is a chronic smoker and chronic alcoholic was brought to the emergency department with a complaints of shortness of breath, which increased in supine position. For the last 3 days on percussion, there is a dull knot in bilateral infrascapular regions, and on auscultation, there is absent breath sounds. Very good. Previous ultrasound is suggestive of hepatomegaly with cirrhosis of liver. Which of the following is the true statement regarding this condition? See, I have marked this because this is a great clue for you. I am expecting a right answer from you guys now. Tell me. हाँ जी बताइए. Community acquired pneumonia. Likely cause is transudative pleural effusion. Likely cause is protein ratio to serum protein ratio more than 0.5. Good reversibility of FEV1 more than 12%. Okay, so guys, put your pens down and understand the concept. Can you please tell me what is this patient is having? Whether this patient is having pneumonia or no pneumonia, first of all. My question is this: what is this patient is having? Whether this patient is, I am giving you three options. My first option is patient is having pneumonia or no pneumonia. Pneumonia. B option is no pneumonia. Third option, patient is having asthma. Fourth patient is having acute exacerbation of COPD. Yes, इनमें से बताइए क्या है? Or none of the above. The fifth option is none of the above. I repeat: pneumonia, no pneumonia, asthma, acute exacerbation of COPD, none of the above. None of the above. Can you please tell me? हाँ जी बताइए क्या है? Waiting for your replies, guys. Okay, ji. So, guys, patient is having no pneumonia. First of all, no pneumonia. Very good. It the no pneumonia, or patient is having nothing. So, my option number five, none of the above was there. Option number five, patient was having none of the above. This is the right option over here. Now, why I said this one is this: had it been the pneumonia wise, patient would have fever, patient would have cough, patient would have fever, patient would have cough. Is there anything which is signifying that the patient is having fever over here? I am not able to segregate that the patient is having fever. तो ये तो rule out हो गया. Okay. Now, what this patient is having, my dear friend, asthma. No, I told you that asthma is a chronic airway limitation with inflammation over there, and the symptoms are shortness of breath, wheeze, chest tightness, cough, and the symptoms vary in time and in intensity. Is there anything which is telling us about the variation in the time and in intensity? No, my dear friend. So asthma is also ruled out. What are we left with? We are left with the option that the patient is having nothing above, none of the above. Now, but if it is none of the above, then what this patient is having? This patient is a clear cut case of effusion. It is pleural effusion. Now, what is this pleural effusion? Yes, my dear friend. Sahu Patel, I absolutely adore your answer that you have given cirrhosis can be a cause of pleural effusion which leads to the dull knot of precursion. Absolutely thumbs up to you. Okay, Sahu Patel, very good. Okay, जी. Sameer sir, very good. Okay. Akhil, very good. Bajinder, okay, very good. Everyone. हाँ जी. चलो देखते हैं. Why this patient is having pleural effusion? So let's discuss about pleural effusion a little bit over here now. So guys, anything else you want to tell me? हाँ जी. So what is pleural effusion, guys? Can you please tell me what is pleural effusion? It is extra accumulation of the fluid in the pleural spaces, right? What is pleural effusion? It is extra accumulation of fluid in the pleural spaces. Understand the concept over here, guys. Suppose, my dear friend, that this is a lung over here. These are the lungs over here, right? This is the chest wall. This is the chest wall over here. This space between this and this is called the pleural space over here. Over here, what do we have? We do have a layer which is attached to the lungs over here. This is called as which layer? This is called as the visceral pleura. And this layer which is attached to the chest wall, this is called as the parietal pleura over here. The space in between these two is called as the pleural spaces, and in between these two spaces there is a continuous fluid flow of the fluid over here at the rate of 0.01 ml per hour. 0.01 ml per hour is the speed or at which this is flowing over here. Now, why do we require this fluid over here in this pleural spaces? See, we have driven in the motor car or we have driven on the motorcycle. We know that to make the engine run smoothly, we need to put the engine oil over there so that there is a good friction over there, right? Okay, so this fluid is basically the purpose of the fluid. Now inhale with me. When we are inhaling, guys, our lungs are going to expand and they are going to glide against the chest wall. If there is no fluid, they will stuck over there and they cannot perform their function properly. So to give a sticky movement over there, or to give the friction over there, this fluid is necessary. Now I am saying that this fluid is continuously flowing at the rate of 0.01 ml per hour. But now my question to all of you is this: if this has been going from 0.01 ml per hour, let's say we are 30 years or let's say we are 20 years of age, we are having a 20 years of age. Where is this fluid gone in these 20 years? This fluid is getting drained into the lymphatic system. So this is the lymphatic system. This fluid has got drained into the lymphatic system and then it has gone into the venous circulation. But due to some reason, this fluid start accumulating over here. Now, what are the two reasons over here? The two reasons or the two causes can be divided into, guys, two main causes can be divided. First main cause can be a transudative causes. It can be a transudative cause. The second can be an exudative cause. The second can be an exudative cause over here. Got my point? Now, transudative is non-infectious. Do remember this thing. It is non-infectious. It is non-infectious over here. Exudative is infectious. Exudative is infectious over here. What are the causes of the transudative pleural effusion? So the causes of the transudative pleural effusion is: first, patient is having congestive heart failure. This is the most common congestive heart failure. This is the most common cause. Second one is hypoproteinemia. Hypoproteinemia. Third one is nephrotic syndrome. Third one is nephrotic syndrome. The fourth can be a cirrhosis of liver. Cirrhosis of liver. Right, these all are the causes where there is non-infectious causes of pleural effusion, or let's say it is a transudative type of pleural effusion. Exudative causes includes, guys, infectious causes like pneumonia, tuberculosis, right, bronchogenic carcinoma, It can be a pulmonary embolism. It can be pulmonary embolism. It can be SLE, some connective tissue disorders, rheumatoid arthritis, right? It can be due to some lymphoma, right? So these all are some of the causes of that exudative type of pleural effusion. Got my point? Okay, Ji. So now, guys, before I proceed further over here, can you please tell me, among all this I have given you the option over here, can you please tell me now that what could be the right answer over here? What could be the right answer over here? Tell me. I have given you the enough clues over here. Hanji, please tell me. Okay. So now the likely cause. See here, I have given you the clue over here. Very good. The patient is having hepatomegaly with cirrhosis of the liver. Now, cirrhosis of liver is over here. We know this liver is responsible to produce the proteins. Now put your pens down and understand the concept over here. We know that this liver is responsible to produce the proteins, and we also know that these proteins, right, if they are not produced in adequate amount, the role of the proteins will not be performed properly. Now coming to the next explanation, what is the role or what is the function of the proteins, particularly if I am talking about albumin? To push the fluid in from the extravascular to the intravascular. Got my point? So what are the proteins they do? They keep on pushing the fluid from intravascular to from extravascular to intravascular. Right. Now already cirrhosis of liver is there. The patient liver is not functioning properly, proteins are not getting produced. So who is going to maintain about the function of the proteins? Means it is not going to push the fluid into the pleural, into the vessels. So wherever they will feel free spaces, the fluid will start accumulating over here. Once the fluid will start accumulating over here, what will start occurring over here? Now the fluid have started accumulating over here. This yellow color, consider it as the fluid over here. This has started accumulating over here. This is whole fluid over here. This whole fluid is started accumulating here. In red, these are the two postophrenic angles over here. What will happen? Now they have gone to this level. They have gone to this level. When you are going to put a stethoscope, you are not going to hear any type of sound in this region. Or when you are going to do the percussion, what type of sound you are going to find? You are going to find some dull, stony, dull note you are going to find over here. Right. So this is a case of a transudative pleural effusion. Likely causes transudative pleural effusion. See, this pleural fluid ratio to serum protein ratio we do discuss in the lights criteria, which is very important. I will discuss in detail when we have a detailed class upon this thing. Okay, Ji. Moving to question number next question. Can you please tell me what is this question is telling us about now? हाँ जी, बताइए, what is the answer? Guys, I think there is some technical issue which is going on. Just a second, let me resolve this issue. Just a second, guys. Okay, now I hope the screen is okay. Okay. So let's discuss about the question now. What is this saying? This question is saying that there is a 65-year-old man presented to your clinic with a complaints of numbness and tingling in his feet. His medical history includes hypertension with controlled, which is controlled with captopril, and type 2 diabetes mellitus, for which he is taking metformin and exenatide, which is for which he is taking metformin and exenatide. Patient reveals decreased pinprick sensation in his bilateral feet, along with some small ulcer in his right heel. Otherwise, unremarkable. HbA1c, very very important, guys. HbA1c is 9.5%. Which of the following is the best next statement in the management of this patient? Which is the next step in the management of this patient? Yes, I am waiting for your replies. Okay, Janvi, your answer is right. Diabetic neuropathy is there. But can you please tell me, at a third patient is already on a dual therapy. You can see metformin and exenatide, right? At third OHA, CT brain switch to insulin therapy, gabapentin. Tell me. Janvi, I am asking you the question. You are saying diabetic neuropathy. So would you like to give gabapentin? Yes. Can you please tell me? हाँ जी बताइए. Okay. So we okay. My question to you before we what we call it as, before we discuss this, I just want to know. I just want to know, guys, that what I want to know is from you is this: how you are going to approach or how you are going to treat a case of diabetes, right? So let's discuss. Let's have a discussion upon that first of all. Yes. What should be the criteria? Yes. My question to all of you is this: what is the normal range of HbA1c? What is the normal range of HbA1c? हाँ जी बताइए. What is the normal range of HbA1c? And what is the treatment goal? Okay, ji. Shubham Gupta. Okay. Before you come with the new answers, majority of you is giving me, make it a thumb rule, right? Make it a thumb rule over here that hyperglycemia, right? So just let me make a table. So this is pre-diabetic. This is a diabetic condition. This is diabetic, and here we do have normal range, right? Here we do have a normal range. So HbA1c, what is the normal range of HbA1c, guys? It should be less than 5.6. It should be less than 5.6%. Okay. We call it as a pre-diabetic. Do remember this thing, very very important. When the HbA1c is 5.7, when the HbA1c is somewhere between 5.7 to 6.4%, 6.4%, and the patient is diabetic when HbA1c is more than 6.5%. Very important, guys. Very important over here. This you have to learn by your heart, right? This you have to learn by your heart. Here you have to learn that if the HbA1c is more than 6.5, the patient is a diabetic patient. The more the HbA1c, the poorly is the uncontrolled diabetes, we call it as. Second question in the MCQs you may encounter is this: what is the treatment goal? My question is this: what is the treatment goal? What is the treatment goal over here? The treatment goal of HbA1c, treatment goal for HbA1c of HbA1c is to keep it, to keep HbA1c less than 7%. Another MCQ, another MCQ. So how much HbA1c needs to be kept? Less than 7%. Treatment goal of HbA1c is less than 7%. Got my point? Right. So these are the two things I just, before the discussion would have started, I just wanted to discuss this thing. Okay, ji. So now let's see what is the treatment of this case. I hope you have written this and I hope you have revised the HbA1cs over here. Now how you are going to approach to a case when the patient is coming to you. Guys, always do look into the MCQ, or if the patient is going to come in your clinic or in your OPD with a case of diabetes, if the HbA1c is more than 9%, I am writing over here, if HbA1c is greater or equal than 9%, right, consider dual therapy. Consider a dual therapy. Consider a dual therapy. Consider a dual therapy. Dual therapy means already in this case the patient is taking two drugs. One, the patient is taking this metformin and the patient is already taking exenatide. So it means the patient is already on dual therapy, but in the MCQ it is given 9.5%. So it is more than 9%, right? It is more than 9%. Sorry, here I just wanted to correct it. It is 9% or equals to 9%. 9% or equal to 9%, or equal to means 8.8, 9.3, somewhere in the range of 8.8 to 9.5, somewhere over here. Got my point? Okay, ji. Okay. Okay. But if patient is having HbA1c of more than 9.5%, or let's say it is straightway written 10%, what you are going to give then, my dear friends? Or in other words, if the blood sugar level is more than 300 milligram per deciliter, 300 milligram per deciliter, what are we going to give over here now, my dear friend? Yes, tell me, my dear friend. So here, my dear friend, consider starting an injectable. Consider starting injectable insulin therapy. Insulin therapy. Very important over here. Got my point? You may encounter anything. You may encounter this one or you may encounter this one if it is more than 300 milligram per deciliter. ठीक है जी. So here in this question, although you have given me the right answer over here, that the patient was having a, patient was having a diabetic neuropathy, patient is already, do we need to add a third OHA? Yes, we can add a third OHA, but if, my dear friend, if the HbA1c would have approximately 9% or near about 9%, but here it is more than 9%, means the patient is having more than 9.5, near to 10%. So we need to control his blood sugars aggressively. That's why we have to inject the insulin therapy. Once we have a HbA1c lesser than 9, we can shift the patient to a triple therapy, and our target goal should be to achieve about HbA1c of 7%. I have discussed earlier with you guys. Right. So this was all from my side today, guys. I hope you have answered. You have pretty well answered me all the questions, and I really appreciate your efforts. So if you do have any queries or anything, you can still message me on the app, on Unacademy app, right? And yes, anything, any other question you want to ask? Hanji guys, anything else you want to ask, or something is not clear? Okay. So guys, I really appreciate your efforts and your times. Keep on studying well, keep on revising the things, right? And stay tuned to Unacademy and keep on reading the medicine, guys. Thank you very much. Take care. Good night.